Hi, everyone. Welcome to our ICARE Genetics Case Conference for November. I'm Tua Pell. So these are just in a nutshell. Here are our referral numbers, easy to refer to our registry as well for anyone who is wanting to submit cases for presentation to this case conference. We've tried to make it as easy as possible to submit cases. So thank you all for your participation. So just a few ICARE focused efforts. We're continuing to collaborate with our Toronto collaborators, Drs. Kelly Metcalf, Stephen Nayrod, on our hereditary breast cancer treatment study. So yes, please, we appreciate everyone that's already been referring patients with breast cancer and PALB2, ATM, and CHEK2. We also continue to collaborate with Dr. Mark Tishkowitz on his efforts focused on PALB2. And then my colleague Sonia Reed and I are working on a study to focused on characterization of breast cancers in BRCA carriers, PALB2, ATM, and CHEK2 carriers. And then our clinical trial focused on enhancing or testing strategies to enhance cancer risk management and family communication among individuals with inherited cancer is still ongoing. The trial's underway. We're really excited. We've recruited more than half of our participants, so somewhere around 400 or so. So please continue to refer to our registry for consideration of inclusion in this trial if they're interested. We continue to be active on social media. Here are just an example of our posts over the last month. And again, follow us on your social media platform of choice. So with that, I wanted to get started on the first case, and then I will introduce our guest expert. So this is a case where the proband is a 40-year-old female with stage 3 triple positive left breast cancer, which was diagnosed a couple of years back, so at age 38. There was a TP53 likely pathogenic variant, splice acceptor. So the question here, I'm just going to go through the family history really quick. So we have here the patient. Her sister had testing, was negative. Sister's son, again, had testing. There was an RB, retinoblastoma diagnosis, again, was negative for the TP53 mutation. The mom had breast cancer diagnosed at age 34. This was back in 1993 when she passed away, so there was no testing done. The mom's sister had testing age 50. There's a diagnosis of breast cancer at age 51. Her results were negative, but the reason I bring attention here is there is some pancreatic cancer in the blue. So the mother's father had pancreatic cancer, and then 3 of his sisters had pancreatic cancer. So it's a strong history, but again, there's a lot of negative people in the family. So with that, consideration of pancreatic screening came up for this patient. So I wanted our guest expert to comment on it, but let me introduce you to our guest expert first, which is Dr. Bryson Katona, based at Penn Medicine, Perlman Center for Advanced Medicine. So Dr. Katona is assistant professor of medicine in the Division of Gastroenterology Hepatology at Penn. He's director of the GI Cancer Genetics Program. He's a physician scientist, did his initial training at UPenn, then his MD and PhD at WashU, and then postdoc back at UPenn. And he is also the current president of the Collaborative Group of the Americas Inherited Gastrointestinal Cancer, so better known as CGA. So I wanted to bring in Dr. Katona to comment on the case, and then he's got a great presentation lined up.
Great. Well, thank you so much for the invitation to come talk today about a topic that I deal with clinically daily and that I really enjoy talking about. So yeah, I'd love to talk about the case a little bit. Um, we go back. I'm going to go back to the case real quickly here. Okay. Yeah. So I assume that this particular patient was going to be you all would be following her like she has LFS. I didn't have a chance to look at the variant specifically, but yeah. So in this case, you know, um, we haven't totally defined, what lineage the LFS is coming from, or whether or not it's de novo. But it seems to be coming from that maternal side, and I think in this case, I mean, I would personally err on the side of offering her screening. In LFS, we typically will start similar to a lot of the other genetic predisposition syndromes at age 50 or 10 years younger than the youngest pancreatic cancer. Now, there was a really young one over here, although, you're getting a little bit far removed from the proband. I think with LFS, probably the more important considerations are that, unfortunately, you can't really rely on the whole body MRI for screening because it's just not sensitive enough for the pancreas. And so, if you were going to do screening on her, you would have to either do an endoscopic ultrasound, which could be paired with the colonoscopy and upper endoscopy she'll be getting every couple years, or have to do a dedicated MRI abdomen. But unfortunately, the whole body imaging just isn't sensitive enough. But I would definitely err on the side of offering it to her. Although, yeah, I think waiting till closer to 50 is probably reasonable.
Okay, thank you. That is what we did. We sent to Kira. So this is one of Kira's patients.
All right. So yeah, it's my pleasure today to talk about pancreatic cancer screening. I was told to try to keep this to about 15 minutes or so. This is normally a talk I give in about 45 minutes, so I will not waste any time, and I will get started here. Here are my disclosures. So today what we'll cover is really kind of do a rapid whirlwind tour through pancreatic cancer screening, talking about first risk of pancreatic cancer, then talk about who we should be sending for screening, how screening should be performed, and then review some of the recent data looking at screening outcomes. So as far as risk of pancreatic cancer, in the general population, the lifetime risk of pancreatic cancer is not that high. I usually typically quote patients for an average risk about a 1 to 1.5% lifetime risk of pancreatic cancer. Of course, we know that risk of pancreatic cancer it pales in comparison to the proportion of cancer-related deaths that result from pancreatic cancer. Now, of pancreatic cancers, about 90% are thought to be due to sporadic, with about 10% due to either a known germline genetic susceptibility or a strong family history. And of those risks in these high-risk individuals, we know that risk is proportional to the number of individuals in the family that had pancreatic cancer. So the more individuals affected, the higher one's risk. There are also multiple different genes that can increase that risk, including the hereditary breast cancer genes, including BRCA1 and 2, ATM, and PALB2, the Lynch syndrome genes, exclusive of PMS2, where there has not been convincing evidence that there is increased pancreatic cancer risk. And then some of the rarer syndromes, such as CDKN2A, Leaf-Raumeni syndrome due to a TP53 mutation, or Poit-Jaeger syndrome, and lastly, hereditary pancreatitis as well. So many different conditions out there that increase risk. But I really want to get to screening, which is the main area that I want to cover. And first, when we think about sending somebody for pancreatic cancer screening, in the ideal world, what should a pancreatic cancer screening test do? So this is getting kind of very fundamental and basic about the question. But with a pancreatic cancer screening test, we really want to be able to detect a cancer or a precancer at an earlier stage. We want to be able to do something because we found this cancer earlier. So in the setting of pancreatic cancer, we want to be able to take this patient for surgery. We ultimately want whatever we do to improve survival from the cancer. And of course, we don't want to create more harm than good. And in the ideal world, it would be cost effective, but that's a tough bar to get over. And because it's so difficult to get a good screening test that's effective, the U.S. Preventative Services Task Force has actually come out with, very strong recommendations saying that in average risk asymptomatic adults, that pancreatic cancer screening should not be offered. However, of course, for high-risk groups, it's a different story, and there are lots of guidelines that are out there that will talk about who is eligible for screening. Unfortunately, all of these guidelines don't totally match up, so there are subtle differences between them. But I think some general principles that can be considered is that if somebody's pancreatic cancer risk over their lifetime approaches 5% or higher, typically that's kind of the threshold where we would definitely recommend screening. Of course, individuals have to be appropriately aged, and so we know that pancreatic cancer is not a cancer that typically affects younger individuals. The patient should be an acceptable surgical candidate, and so if you have a patient who could not undergo or withstand surgical resection for an early pancreatic cancer, you probably should not be screening them. And then ideally, patients before they embark on screening should have a thorough discussion of the limitations about screening, that there is cost associated with it. There are high rates of incidental findings, and although there is data supporting the benefits, this is an area where there's still a little bit of uncertainty. So thinking about the groups that are eligible for screening, we have the first three syndromes where family history is not required for eligibility. So that includes Poit-Jaeger syndrome, carriers of CDKN2A mutations, or individuals with hereditary pancreatitis. And for the hereditary pancreatitis, it is important that the individual have evidence of clinical pancreatitis. So you will find some carriers of these genes that have never had pancreatitis, and those individuals, would not necessarily need to be screened. Now, there are also individuals that are screened based on family history alone. And so these are individuals with familial pancreatic cancer, which is when you have two relatives who have pancreatic cancer that are directly related to one another. And then your patient would be then directly related to one of these two individuals. And then finally, we have our hereditary genetic syndromes that do technically require a family history, including carriers of a BRCA1 or 2 ATM or PALB2 mutation, individuals with Li-Fraumeni syndrome, as well as Lynch syndrome. But typically for these individuals, they need to have a first or second degree relative with pancreatic cancer to really truly qualify. But I will ask, though, especially for these individuals with hereditary breast cancer risk, should we be considering screening in those individuals who do not have a family history of pancreatic cancer? And the reason that I bring this up is that we know that when you use family history as a criteria for deciding whether or not someone gets screening or not, there are certainly biases that can play into this. So sometimes patients have very small families, and so they may not have many individuals who would be at risk for pancreatic cancer. Sometimes people don't know their family history, or what history they do know is incorrect. And especially when we're talking about hereditary cancer risk syndromes, sometimes people have died very early from other cancers. And so again, you just have less individuals who are at risk of developing, say, for example, pancreatic cancer. And I think what's also striking, and I think it surprises a lot of patients when we talk about this, is that the majority of pancreatic cancers in these gene mutation carriers actually occur in families where there's no family history of pancreatic cancer. And so we've been asking this question for a long time here at Penn about whether or not it's right to use family history as eligibility criteria for screening, BRCA1 and 2 carriers. So we actually started a study screening these individuals. We started this study almost 10 years ago now, where we've been offering individuals who are carrying a BRCA1 or 2, PALB2 or ATM mutation, we've been offering them pancreatic cancer screening in the absence of a family history of pancreatic cancer. And while I don't have time to go through the details, if you're interested, we published the initial interim results of this study a couple years ago in Cancer Prevention Research. But what we found was that we were having fairly similar rates of finding on these individuals compared to individuals that do have a family history of pancreatic cancer. And we also found that screening could be done very safely in these individuals. Unfortunately, after the year after this paper was published, the American Society for Gastrointestinal Endoscopy came out with these new guidelines, which I think really shook the field. These were published about a year ago, where they recommended that all BRCA1 and 2 carriers, as well as all PALB2 carriers, undergo pancreatic cancer screening, really regardless of family history. So this has definitely helped from my perspective, from an insurance perspective. But I think a lot of places now are seeing more and more of these carriers without a family history who are coming in for screening. Now, if you're going to do pancreatic cancer screening, how should it be performed? So we'll talk about imaging, blood work, and then pancreatic cancer screening studies. As far as imaging, this is really the cornerstone of pancreatic cancer screening, and really should be done with only MRI with and without IV contrast or endoscopic ultrasound. We don't think that CT scan or transabdominal ultrasound are really sensitive enough to be used. And when comparing MRI and EUS, we know that MRI is the big pro is that it's non-invasive and it is better for detecting cysts, whereas EUS is much better for detecting solid lesions, which represent the vast majority of early pancreatic cancers. Certainly, there are cons to both of these procedures, but both of them have very high incidental finding rates, and so we're finding something on the pancreas in about a third of patients, and they're certainly expensive as well. But I tend to prefer, at least in my practice, I like to mix in EUS because I think in experienced hands, it really is a better test. And we've had multiple cases of early stage 1 pancreatic cancers that have been detected on EUS that have not been able to be seen on MRI. And so all of the patients that we follow here at Penn, in most cases, they're either getting alternating EUS and MRI, or they're getting only EUS. Now, for blood work, there's been a lot of study of CA19-9 as a potential pancreatic cancer early detection test. However, at this point, I would say it's not an ideal test and should not be used alone for individuals who are at high risk. I think that if there is a multi-analyte blood test that's eventually brought to market down the road, CA19-9, will likely be a part of it. But I would not recommend checking CA19-9 on a regular basis on these high-risk individuals. There's been some really interesting data about diabetes and fasting blood sugar. What's been shown is that in a subset of individuals who develop pancreatic cancer, up to 3 years prior to the time of diagnosis, you can see alterations in blood glucose levels and even development of diabetes. And so if somebody develops diabetes or has diabetes and it becomes much more difficult to control, kind of in midlife, there could be concern that a pancreatic cancer is developing. And so for my patients, I will typically recommend they get screened for diabetes on a yearly basis. And if they develop new diabetes, or if they had diabetes that has been constant for a while and it becomes much more difficult to control, I'll typically recommend Q6-month imaging for a couple years afterwards, just in the event that a new pancreatic cancer is developing. There's been a lot of work looking at other blood-based tests for pancreatic cancer early detection. Gallery test obviously is getting tons of press now. If you look at the data for how Gallery performs for pancreatic cancer, it has fairly low sensitivity for stage 1 and stage 2 pancreatic cancer, and so I don't think that this is a reasonable alternative for high-risk individuals. You may also have heard about the IMRAY PanCan-D test. This was a test that was a blood test developed by a company called Immunovia. It was developed specifically for pancreatic cancer early detection. It had fairly good sensitivity and specificity in a validation study. It was on the market for a little over 18 months. However, the company actually pulled it off the market this summer as they're trying to retool their algorithm. So not currently available now, but may be back on the market, hopefully in the near future. So apart from monitoring diabetes, I don't think any of the other blood tests are really ready for prime time yet. I do think, though, that anybody getting pancreatic cancer screening, if possible, should be enrolled in a pancreatic cancer early detection study. Two that we participate in at Penn are the CAPS-5 study. This is a National Cancer Institute funded study. I think we're in our 8th or 9th year now, with locations primarily in the Northeast. There's also the newer consortium called the PROCEED Consortium. This is a rapidly growing consortium. I think it's up to like 40 centers now, with over 5,000 patients who are being followed. Centers across the US and multiple institutions throughout the world. But it's really important for patients who are undergoing pancreatic cancer screening that we have the opportunity to collect data on them so that we can better refine our processes moving forward. And then finally, in the last couple minutes here, talk a little bit about some of the newer data looking at pancreatic cancer screening outcomes. So there have been several studies in this space, but I'll just highlight two of the more recent ones that I think are the most impactful. This is a study that was published earlier this year, coming from Netherlands. And for this particular study, they looked at CDKN2A carriers who were undergoing pancreatic cancer surveillance. They have a very large CDKN2A population that's followed in the Netherlands. And they matched these 1 to 5 to pancreatic cancers that were detected outside of surveillance. And if you compare those found outside of surveillance versus surveillance, what you can see is that in those outside of surveillance, about 3/4 were either stage 3 or stage 4. Whereas if you look at those in surveillance, only about 1/4 were stage 3 or stage 4. And so in this particular study, pancreatic surveillance did substantially downstage the pancreatic cancers in these individuals. Now, also, they also looked at changes in overall survival. And they found that individuals who had surveillance detected cancers had about a 2-fold increase in median survival compared to those detected outside of surveillance. Now, there was also late last year, there was data that was published from the CAPS-5 study, which is the NCI-funded study that we've been participating in at Penn. And I think this is very promising data, looking at about 1,500 high-risk individuals who are undergoing regular pancreatic cancer screening. In this particular study, what was found was that individuals who had pancreatic cancers detected during screening, the vast majority of these were stage 1 or stage 2, with only about 1/4 of them being stage 3 or 4. And for those cancers detected outside of screening, almost all of those presented at stage 4. I think importantly, if you look at median survival and 5-year survival, for pancreatic cancers detected during screening, median survival was close to 10 years, and about 3/4 of patients survived 5 years. And you compare that to cancers detected outside of screening, where your median survival was only 1.5 years. And so, very, very dramatic differences between the groups. And so I think that, this data really shows that for high-risk individuals under careful surveillance, the screening can downstage pancreatic cancer and can improve long-term survival. However, it is important to note that even in these high-risk individuals, pancreatic cancer is not common. And so you do need to screen a lot of people to actually find high-risk lesions. There have been 2 meta-analyses that have been done recently, showing that you probably need to screen a little bit over 100 patients to find one high-risk lesion. And so cost effectiveness is a story for probably another day. So this is a kind of a whirlwind tour of pancreatic cancer screening, but I just want to leave you with a couple take-home points before we get to some more cases. And of course, happy to discuss any of this in more detail as well. But I do think pancreatic cancer screening should be considered if individuals are eligible. But I do think these individuals should have a discussion of the risks, benefits, and limitations before they embark on a pancreatic cancer screening program. If you do screening, I think you should do annual imaging of the pancreas, either with EUS or MRI. And I would argue that at least every other year, an individual should have an EUS if possible. And then I think you should also follow blood glucose, or ideally hemoglobin A1C. Ideally, these individuals should all be enrolled in clinical studies, and certainly we need more research in this area. We need better screening strategies. We need biomarkers to allow for blood-based testing. we need to improve our imaging, and ideally incorporate AI into this imaging as well. And I think we need to do a better job of risk stratification because, as we do it now, I think screening a lot of people. I think we're over screening a lot of people, and probably under screening some as well. So we definitely need better risk stratification. So thank you again for the opportunity to talk today. I'd love to answer any questions about the presentation, or I know we have more cases to go through as well.
So thank you, Bryson. Excellent, excellent presentation. So I'm just looking at the chat. Talia Donnenberg, one of our colleagues from Miami, question: at what age to start hemoglobin A1C, and would you modify based on BMI, lifestyle, in brackets smoking history?
Yeah, it's a great question. When typically by the time I come see patients, they're coming to see me when they're ready to start screening, and so I usually start it right then. I think if you had a younger individual, so if you have like a 30-year-old, BRCA carrier who develops diabetes, I think again, with the age being so low, I wouldn't make too much of that. So I would basically start the yearly A1C screening at the time, they get screening. And I think you do have to take into account other factors. And so, if somebody gains 100 pounds over a year and their A1C goes up a point, I feel much less worried about that compared to, on the flip side, somebody with an increasing A1C who's losing weight. And so I do think that there has to be some personalization of the A1C levels. Unfortunately, none of the guidelines yet have included what to do with A1C in pancreatic cancer screening. But given all the data that's come out in this space, I'm hopeful that there will be some more formal kind of structured guidance for how to deal with that in the future.
Perfect. And we also have Cameron has his hand raised. Cameron is our pancreatic, or he's the head of surgical oncology at Vanderbilt, but also our brilliant pancreatic cancer surgeon here.
Hey, Dr. Katona. Really enjoyed your talk. Question for you regarding these mutations as well as the pre-malignant cyst. I know you had a short amount of time to talk about the risk, but if you can comment on IPMNs in the presence, or mucinous cystic neoplasm in the presence of some of these mutations.
Yeah, it's a great question. I think a lot of the data looking at pancreatic imaging findings in these mutation carriers, I think actually we're finding cysts in a very large number of people. I mean, in our series that we've looked in several series, it seems to be about 30% of individuals. And I think that's probably a little bit higher than what we might expect in the general population. But, at this point, I don't think we have any clear enough data on, what the risk of progression is in these mutation carriers, just because the numbers are still so small. Even all of these pancreatic cancer screening studies, that are in JCO and gastro and stuff, the number of people that actually convert to pancreatic cancer, it's like, just a handful, because we're still in the data collection process. So, when we see a cyst in one of these individuals, we're seeing these low risk cysts very, very frequently. I always tell patients probably about a third chance that you'll have a low risk cyst. But I'd say that our therapeutic endoscopists who are following these patients, they typically won't back off and go to like 2-year intervals or anything like that. They'll stay on yearly intervals, but we just monitor them like any other cysts for now.
And I'm just going to have Elizabeth has had her hand up for a while. So Elizabeth, take it away.
Apologies, that might have been an error on my part. Sorry.
Oh, okay. We have some more questions though, Bryson. So are my colleague Nicoletta. So well, actually here, wait. This is a great question. First, Kimberly Lane, question from her. Do you think a general gastroenterologist is capable of handling screening for individuals at high risk for pancreatic cancer, or should they see a specialist who has more focus / background in this area?
Yeah, that is a great question, and I think one that I get asked pretty frequently. I think especially when you're talking about EUS, I think it's very provider dependent. There are obviously a lot of great gastroenterologists out there who do EUS frequently. So I think as long as somebody's doing a very high volume of EUS, I imagine it would be okay. I mean, I don't think somebody who's doing maybe one or a couple EUSs a month, may not be the best person to screen. But I think one other benefit to sending people to a referral center would just be so that this data can be captured in a lot of these ongoing pancreatic cancer early detection studies where we just clearly need higher numbers and more data.
Okay, so another question here is for carriers of CFTR, CTRC, and FDR with pancreatic cancer, would you offer pancreatic cancer screening? I think this question really is, in the context of these genes, are those high enough risk? Because if they have pancreatic cancer, it doesn't matter.
Yeah, so for a lot of these, these hereditary pancreatitis genes, the classic one is PRSS1. But these other genes like CFTR, CTRC, and then even SPINK1, which we find a lot of asymptomatic carriers. I think unless the person has a chronic, a hereditary pancreatitis or chronic pancreatitis phenotype, I don't think that the data supports screening for them. Because basically these genes intrinsically don't increase the pancreatic cancer risk. The only reason they increase the pancreatic cancer risk is because they can be associated with increased inflammation, which over time leads to pancreatic scarring and subsequent increased pancreatic cancer risk. So I'd say you only consider screening if there's a clinical phenotype of hereditary pancreatitis.
Okay, and we'll do one last question and then we'll have Kira present some of her cases. In your experience, how successful is insurance coverage for pancreatic cancer screening for patients who meet the criteria or are borderline meeting?
Yeah, that's a great question because cost is always a major issue. I would say that pre-2022, we had a lot better luck getting EUSs covered than we did MRIs for patients who didn't quite meet criteria. So say, for example, the BRCA 1 and 2 carriers who didn't have a family history. I think a lot of EUSs kind of slip through the cracks and don't necessarily get all the scrutiny that these MRIs get. But with the ASGE paper last year recommending all BRCA 1 and 2 and PALB2 carriers get pancreatic cancer screening, that's made our lives a lot easier, and I'm doing far fewer peer-to-peers as I think knowledge of that gets out there. But anybody who meets like standard NCCN criteria, whether it be family history or gene mutation plus a relative, we typically don't have any issue getting either MRI nor EUS covered in those individuals.
Okay, perfect. We'll go on to our second case. Kira, take it away.
Thank you, Dr. Powell, and thank you, Dr. Katona, for that great talk. So this first case is a 71-year-old female who initially presented to us with radiographic findings concerning for a pancreatic tail cyst and had a strong family history of pancreas cancer. It was recommended that she undergo a distal pancreatectomy and splenectomy, which she had in January of 2022. Her pathology was consistent with otherwise a low-grade intraductal papillary mucinous neoplasm, or IPMN, and measured roughly about 1.3 centimeters. It was negative for any high-grade dysplasia or carcinoma, So surveillance was recommended. Her post-op course was complicated by a pancreatic leak. She had some prolonged drain placement, but then eventually this resolved, and we just continued with ongoing surveillance screening with imaging. So on her subsequent studies, it did show a persistent collection. And let me go to the next slide.
Kira, can I ask you a quick question before you? Why was the decision made to take her for distal pancreatectomy? Based on, was there some concerning cytology from an FNA of that cyst, or because it looks like it was a pretty small cyst?
Yes, radiographically, she had some ductal dilation and I think some other high risk features that did qualify her for resection at that particular time.
Oh, okay. Okay. Thank you.
Yeah. So as you can see, based off of her pedigree, and she did undergo further genetic testing. She had a BARD1 VUS, but otherwise no other pathogenic mutations. Did have a first and second degree relative, which also had past of pancreas cancer. And then during further management, her studies did show this ongoing collection and then showed some interval increase in size back in January of 2021. There was no other concerning findings in the pancreas, but she did develop a 9mm hepatic lobe hypodensity, which was not evident on prior studies. Unfortunately, given the size, wasn't very well characterized and wasn't amendable to biopsy. So we did some shorter interval imaging with an MRI with EOVIST about a couple months later. In April of 2021, it showed numerous hypovascular peripherally enhancing lesions that were concerning for hepatic metastases. Her CA-19-9 was roughly about 87,000, and she passed 1 month following. So she has 3 daughters, and one of which has since established ongoing surveillance with me, given her mom's passing, and then of course her strong family history. The patient had no, her daughter, who's 43, has no notable mutations, but on her baseline imaging, she was found to have several sub-centimeter cysts throughout the pancreas, with the most dominant being roughly about 5 millimeters. So my question is, really had to set the stage to kind of talk about her daughter. Would this patient need biannual surveillance? What would be maybe the recommendation regarding further management, given these findings radiographically as well as her family history?
Yeah, interesting case, and sad case. I guess especially for her mother, about this pancreatic cancer that developed. Can't really exactly tell where that was from, but I mean, from this particular family, I mean, this young woman, this 43-year-old woman's mother and maternal grandmother, both with pancreatic cancer, would kind of qualify her for familial pancreatic cancer, in the absence of any genetic predisposition. So, she certainly would qualify for screening, although neither her mom nor her grandmother were young when they had it. So, I would personally just monitor her based on her cysts for now, and wouldn't start annual imaging until age 50. I mean, typically for our new onset cysts, these are fairly small. Biggest one being 5 millimeters. I would usually repeat an MRI in a year, and then I would just probably do Q2 MRIs until Q2 year MRIs until age 50, and then start screening her more aggressively with annual imaging.
Okay.
I know, I think, I spend a lot of time talking about EUS being kind of a more sensitive test, but in these younger individuals where, technically we're not screening her for pancreatic cancer yet, we're just following her cysts. In these younger individuals, I would not, put her through the extra risk of an EUS now. I would wait until probably, after she hits age 50 and would qualify for surveillance then. What were you guys thinking or planning?
I was just continuing with MRI of her abdomen with MRCP. I think that right now, especially given the sensitivity behind what happened with her mom, I think that there's a lot of heightened concern there. And so that's kind of what we had agreed upon right now. And so that's kind of where we've been.
Yeah, and if you wanted to be more aggressive, I mean, I think, once you find a cyst in there, I mean, even if you wanted to, do yearly for a couple of years, if she was, very anxious and wanted that, I mean, you'd probably be able to get them reimbursed.
Yeah.
I know for a lot of our patients who are kind of like borderline, meeting screening criteria, whenever we would find a little tiny couple millimeter cyst, we were actually felt like we were pretty lucky, because then insurance wouldn't give us any trouble moving forward, because you could add that to as a diagnostic code.
Yeah, no, I've found that as well. That unfortunately that then they have a reason to continue forward with surveillance, and so yeah. All right. Well, thank you so much.
Okay, I think Kira, the next case is yours too.
Yes. So this is a 30-year-old female who was referred to us, incidentally noted to have what was thought to be a pancreatic mass when she was 22 weeks pregnant. However, she had undergone an EUS, which actually revealed pancreatic stones and chronic pancreatitis. And then she was tested based off of her findings, underwent some hereditary testing in 2021, which revealed a SPINK1 mutation. And then she was retested in 2022 and also found to have a PALB2 mutation, pathogenic variant. So she does have a family history, as you can see, of a first and second degree relative who have also tested positive for PALB2. We have been seeing her for management of her chronic pancreatitis, and we've recommended potentially total pancreatectomy, but just wanted to present her case and get your thoughts on what you would recommend and what her lifetime long-term risk would be given these mutations.
Interesting case. How old was her very first episode of pancreatitis?
So she was in her early 20s. And so she had, it sounded like a long-term history of abdominal pain and what otherwise was diagnosed initially as irritable bowel. And just her symptoms actually improved, it sounded like, with pregnancy. And then just she's had these reoccurring bouts since then of chronic pancreatitis, but currently she actually would like to get pregnant again. So I think right now she's kind of holding off and doesn't want any surgical management and just wants otherwise, if it's possible, maybe endoscopic based procedures if she becomes symptomatic enough.
Yeah. Interesting case, but very tough case as well, with her being so young. I think with SPINK1, and she was just a monoallelic carrier, right? She didn't have she wasn't homozygous.
I don't know. I know, Dr. Powell, maybe you can comment more on that.
No, she wasn't biallelic from my recollection. It's
Okay.
Carrier.
Okay. Yeah, so for SPINK1, and this particular SPINK1 variant is the kind of, it's like the most common one in the US and in Europe. It's actually fairly common in the general population. Like if you screened everybody, I think it's like they estimate like 1 to 2% of people will have a SPINK1 risk allele, but but really only, a very, very small percentage, only like, 1 or 2% of those that carry a risk allele will actually have any clinical evidence of pancreatitis. And I always think about a monoallelic SPINK1 as like it's a risk modifier. So it's likely she had some other process that was, causing her pancreas to be inflamed. And then it's then that kind of, the SPINK1 kind of amplifies that process. Usually we don't, in the absence of another process, usually you don't see SPINK1, a single copy of SPINK1 causing pancreatitis alone. I think as far as, the risk, she's only had chronic pancreatitis for less than 10 years. So I think, and granted, she has a PALB2 mutation as well, but, I think her pancreatic cancer risk over the next, 5 years or so is not like super, is not going to be super high because, again, the pancreatitis has been more recent. It'd be a different story if she was developing pancreatitis from like 5 years, from like 5 years old on. So I think if you were considering surgery now, it would be, it should only be for, for symptomatic reasons and not necessarily for pancreatic cancer risk reduction. I mean, that would just be my thought.
Okay. So just as far as screening goes, you're just screening based more off of the PALB2 rather than the SPINK1 mutation.
Yeah, I mean, the SPINK1 with, and there's like zero data about people with hereditary pancreatitis who have another pancreatic cancer risk gene. So, I don't know what the right time to screen was. If she didn't have the PALB2 mutation and she had SPINK1 and hereditary pancreatitis, then, if she developed her first episode after age 20, typically we wouldn't start screening her till 40. But I mean, at this point, she's got a lot going on. I mean, I think you could probably screen her, you could probably screen her now, but I think that the risk probably in the next 5 years is going to be, not that high. And I think doing a total pancreatectomy, that is a huge surgery. And, I would say if that's being done for symptoms, that's a different story. And, if it's done for symptoms, that's fine. But I don't, I wouldn't think that would be necessary just to manage pancreatic cancer risk alone.
Okay. All right. Thank you.
There's just another question here, just really quickly. Any screening recommendations for family members of patients with a pathogenic mutation in the NTHL1 gene? But again, I'm guessing it's just carrier of NTHL1 because that one's like an autosomal recessive condition, right?
Yeah, NTHL1 is autosomal recessive. It gives like a colon polyposis and colon cancer phenotype. Even in the homozygotes, I don't think we have any convincing evidence yet that there's increased pancreatic cancer risk, although data is like extraordinarily limited still. But yeah, for NTHL1 monoallelic carriers, I don't think there's actually any risk to screen for any cancer, across the board.
Okay, Kira, next case.
All right, this is my last case. So this is a 45-year-old female that has a CDKN2 mutation, a pathogenic variant that her mother passed, unfortunately, of pancreatic adenocarcinoma at age 44. So I've been seeing her for surveillance, and on her baseline imaging, she was noted to have a 5-millimeter pancreatic cyst in the uncinate process. And so just given some of the talk about CDKN2 and the increased risk, given these radiographic findings and her mutation, is this somebody that you would do biannual surveillance on, or definitely alternating EUS? What's your thoughts?
Yeah, so I think, these CDKN2A carriers are just very, very high risk. Of course, this is obviously one of the ones where we start screening a lot earlier. So yeah, I mean, I would screen her I would definitely screen this patient aggressively, and I would alternate EUS and MRI. A lot of times, if we have CDKN2A carriers, I think long term, yearly imaging is probably enough. But a lot of times, initially when we're getting started, we'll do, we'll get a baseline. Let's see, what did she have? She had a MRI.
Yes,
Um,
MRI,
yeah,
MRCP.
so I mean, yeah, so I think, sometimes in these very high risk patients, initially you can some places I know will actually get EUS and MRI together at the same time, but typically our practice will be if especially if we find something like a little cyst or something in there, we'll get a second imaging study 6 months later, and then if everything looks stable, then go to yearly imaging after that. So, for this patient, this was her first screening exam. She had a 5 millimeter cyst. I think it'd be reasonable to, repeat an EUS on her in 6 months. And then after that, you could then stretch it out to every year, assuming that everything stayed stable.
Okay.
But yeah, these are very, very high risk patients, and especially when you see a CDKN2A carrier with a young pancreatic cancer in the family, I definitely worry about these. Did her brother test positive too?
I don't think her brother was tested. I think he opted against, if I remember correctly.
Yeah, yeah, and interesting. I mean, but there's a lot of melanoma on the paternal side, so it's possible that this could be, the CDKN2A could be coming from the paternal side. I guess we don't have testing in dad either.
No. Mm-mm.
Yeah, so I mean, it could, because that looks fairly classic as well. But since you don't need a family history for CDKN2A, regardless of which side of the family it's coming from, I would screen her aggressively. But I would definitely have dad tested too, because we have seen, definitely have seen crazier things.
Okay. Yeah. Thank you for the suggestion.
I think we're gonna have time for just one more case, but let me get this one going. So this is a patient of mine, 65-year-old with Li-Fraumeni syndrome, tested after her daughter right here was found to have triple positive breast cancer, stage 3. Declined MRI. Okay, so this patient, she didn't want an MRI because she's a physician, this patient up here, but she didn't want to be super aggressive. I don't know. So her daughter, who is also a physician, convinced her mom to at least do a CT scan. Well, the story here is on the CT scan, there was a 0.8 centimeter mass on the tail of the pancreas, which ended up being pancreatic cancer. So she is super lucky. Status post-surgical resection, but it wasn't a Whipple, it was just a straight resection, super early. A path showed adenocarcinoma. She got platinum-based chemo, has ongoing neuropathy as a side effect of the chemo. So she also, the history is, it's a typo, status post-colectomy. She had inflammatory bowel disease. She had her colectomy done years ago. I don't remember exactly when. Gets endoscopy every 3 years. She should be getting high-risk breast screening, but her last mammogram was 5 years ago. So we're trying to get her current with that. I'm getting her to do a total body and brain MRI annually. Skin exam she'll need annually as well. And she has part of her pancreas left. So she doesn't have a family history, but she's got a personal history. And I just realized as I was going through this case, I sent her to Kira to do the pancreatic cancer screening, but just wanted your thoughts on, in guidelines, if you have a resectable like you don't have a first or second degree relative, but you have a personal history. So you would think that that qualifies, but that might be a gap in our guidelines is what I was thinking. I don't know.
Yeah, it's a great question. Yeah, I agree. I would definitely screen her as well. And even if you did ignore her, we know that the LFS is probably coming from, I mean, unless she's a de novo, but coming from her paternal side. So she technically has a second degree relative with the pancreatic cancer. So she would meet NCCN criteria. But yeah, I agree. If somebody has, just half of their pancreas left, and they're in one of these high risk groups, I would screen them. And I think that's something we should, it would be good to make sure that language is clear, because if you read the NCCN, it wouldn't point you in that direction. A lot of times these patients, she's getting upper endoscopy every 3 years. I think that's we try to use those regular scopes that are happening anyway. So, like in patients with Lynch syndrome that have pancreatic cancer history as well, or a family history of pancreatic cancer, just use those upper endoscopies as time to sneak in an EUS to screen at the same time, just because the burden of screening is just so much for these patients.
That is a great idea. I didn't even think of that. Yeah, no, that's a fantastic idea.
Yeah, and I think we try to do that pretty frequently. I mean, the advanced endoscopists shouldn't have a problem pushing down two different. It is technically a different scope, but they shouldn't have a problem doing that. And then, if she had a distal pancreatectomy, they'll be able to see they should be able to visualize the head of the pancreas still okay, just because the duodenum and everything else is still all intact.
Okay, and Kira, maybe we can talk offline. I'm going to loop you in when I order because I'm just trying to think at Vanderbilt how we can get these synergized if they're getting an endoscopy to sneak in.
Yes.
The endoscopic ultra. I don't know that we have a smooth process in place, but we could talk, like Dr. Ness does a lot of our high risk screening for our GI inherited predispositions. So we should figure out how we can do it more smoothly. But that is a great point. I hadn't thought of this, and especially for this patient, I worry because she doesn't want to do screenings. And I have both me and her daughter have kind of strong-armed her, and she's compliant and, she will do it, but I don't want to push it too much. We don't want to push our luck too much. So for someone like her, she's willing to do it, but she doesn't want screening to take over her life. And Bryson, I think you mentioned this. This is a lot we're asking these people to do. So we need to be respectful of how can we consolidate care.
Oh, definitely. And, just one quick comment, because I know we're at the end of time, but, thinking about, combining, adding an EUS to an upper endoscopy, that's one thing. But then, we've been doing it the other way, like in BRCA1 and 2 carriers, there's all this emerging data about increased gastric cancer risk in BRCA1 and 2 carriers. So for our BRCA1 and 2 carriers who are coming in for EUSs for pancreatic cancer screening, we're actually having the therapeutic endoscopists do a careful upper endoscopy too, to screen for concerning findings from a gastric cancer perspective. So I think it works both ways. But if you have any high risk patient, I think it really behooves the endoscopist to do 2 careful exams.
Yeah, no, that makes a lot of sense. So with that, Bryson, thank you so much. I already have requests in here to bring you back next year. So we have more requests, depending on your schedule. This was phenomenal.
Well, thank you so much for the invitation. I appreciate it.
And we all struggle with this because it is a new field. Your presentation was awesome. And thank you for the expert guidance. So with that, our next case conference in December, we're also really excited about December 14th. We will have a panel discussion focused on care for gender diverse individuals with or at risk for inherited cancer predisposition. So we have a star panel of guest experts for that session as well. So we look forward to everyone attending, and thank you for attending this time. And again, big thank you to Dr. Katona. Here are our upcoming case conferences. They're also listed on our website. And with that, thank you for your attention.